All right, good evening, everybody, and welcome to another online lecture brought to you by the AMSSM Fellow Online Education Committee. I'll be your moderator tonight, Dr. Myro Lu. And just a reminder, this national lecture is sponsored by the AMSSM Education and Fellowship Committee. And the purpose of these lectures are to serve as an adjunct to your individual program's educational programming. It also provides fellows with direct access to educational experiences with experienced AMSSM members and invited guests. These lectures will also help assist in the CAQ exam preparation. As a reminder that if you haven't already, please mute your device's microphone and turn off your video. After the program, please complete the evaluation, which will be sent at the end of the lecture. And during the lecture, please submit questions to the chat function and include your name in program if you wish, and I'll try to get to them and ask Dr. Lane at the end of the presentation. All right, so tonight it is my pleasure of introducing our speaker, Dr. Allison Lane. Dr. Lane is an emergency and sports medicine physician at the University of Arizona's Banner Health in Tucson, Arizona. She completed her medical school, emergency medicine residency, and sports fellowship, all with the University of Arizona. Dr. Lane is currently an assistant professor and sports medicine faculty with Banner Health. She is currently in a great area of the U.S. for her activities, which include running, hiking, and rock climbing. She also has interest in tactical medicine and is a volunteer law enforcement assist with the Arizona Rangers. All pretty cool. So Dr. Lane, I'll turn the screen over to you now.
All right, thank you. I'll be so impressed if I do this on the first try.
All right, you got it.
Yes, okay. All right, thanks everyone for joining. So I'm going to talk about SC, AC, clavicle, and scapula injuries. So first off, anatomy. Here's a overview of the anatomy that we'll be covering. So right here, your AC joint, we'll talk about AC separation. We've got the clavicle here. So we'll talk a tiny bit about distal clavicle osteolysis, some clavicle fractures. Here's your SC joint. We'll talk about some SC dislocations, and then you have your giant scapula, and we'll talk about some scapula fractures as well. So first off, we'll talk about AC separation. The incidence of this is a pretty decent amount. I'm sure we've all seen some of these. So about 9 to 12% of shoulder girdle injuries. Overall, males and athletes are the people who we tend to see have these. And the mechanism is usually going to be either a direct blow to the shoulder or a fall onto the shoulder itself or an outstretched arm. Specifically, osteology and motion of the AC joint. It's a diarthrodial joint. So you have the articulation of the scapula at the medial acromion here, and then with the lateral clavicle. So really this allows the scapula more motion on the thorax, but primarily the AC joint is for gliding with minimal rotation. There is a little disc in here, a fibrocartilaginous disc, that's similar to the meniscus of the knee, and it tends to involute with some age and disintegrates even by the age of 40. So I have none. When we talk about stability, there's the static and dynamic stabilizers, as we have with most joints. Dynamic, we'll talk about anterior deltoid and trapezius. And then within the static stabilizers, we're talking about the joint capsule itself, as well as the AC ligaments and the CC ligaments. The AC ligaments, which is important, provides horizontal stability. So it's preventing that motion, the anterior posterior motion. The CC ligaments over here are providing that vertical stability, so that superior inferior stability. The conoid ligament right here, named to be kind of like it's a cone, so it's fan shaped and it's more medial of the two. The other portion is the trapezoid ligament, also named nicely because it's slightly trapezial in shape, and it's the more lateral of the two. So when we see AC joint injuries, we're typically seeing pain over that AC joint. So superior aspect of the shoulder and the trap will have some tenderness to the AC joint, the lateral clavicle. You may see some abnormal contour, and you really want to get a good assessment of the stability of that joint. So we're looking for that horizontal stability of the AC ligaments and then the vertical stability with the CC ligaments. We're going to diagnose this with x-rays. So a clavicle series is really what we're looking for here. You get the bilateral AP view of the AC joints, and then you're going to get that Zinka view. So the Zinka is more of a cephalic angled tilt. So with the bilateral AP view, you're going to compare the displacement of the CC measurement to the opposite side. So you're going to look for any displacement. And you're also going to look for distance between the acromion and the clavicle. Then with the Zinka view, so this is how it's shot here. And so you're getting a little bit of that tilt. And so those two views are the primary views you're looking for. Now, you do want to consider getting an axillary view if you're going to be looking specifically for a type 4 AC separation. And that's where that clavicle is going to be more posterior. And you'll actually be able to tell, and I'll show a picture of that later, you'll be able to tell whether it's a posterior or not. We always used to, in the past, do weighted stress views. We really don't use this much longer, but it can have a little bit of help when differentiating from type 2 and 3, but it doesn't usually change management necessarily. So we don't really do that too much. So here's what we're looking for radiographic findings. We have that AC joint here. So we're looking for AC joint widening. Normal is going to be 5 to 8, though it can be smaller as you get older. And then you're also comparing it to the other side. So if it's greater than 2 to 4 millimeters different than the other side, that's going to be an abnormality. And then you're going to be looking at the CC distance here. So normal is going to be 10 to 13. And if you compare it with the other side, having a 5 millimeter difference is going to be abnormal. And then in general, you're going to be looking for superior displacement of the distal clavicle. So you're going to look here, the inferior edge of the acromion, and you want to just make sure it lines up with the inferior edge of the clavicle. And that's just an easy overall way to look at that. Rockwood classification is the most common classification we use to grade the AC joint separations. And this is type 1 is the one I think we see one of the more common ones, where you don't necessarily see anything on exam, but you have a sprained AC ligament, you have a normal CC ligament, you'll have some tenderness to that AC joint, but the x-ray itself is going to look pretty normal. This type of injury is reducible, and these reducible type separations are going to be conservatively managed. So this is really just going to be a sling for a type 1. Then you have type 2. The AC ligament is now torn. You have a sprain of that CC ligament. So on exam, you may see some horizontal instability because that AC ligament is now torn, and that's responsible for that horizontal stability. So on x-ray, you'll see that the AC joint is disrupted, and you may have some increase in that CC distance, but it's going to be less than 25% of the contralateral side because that CC ligament is just sprained, not completely torn. And this one's also reducible and will just be conservatively managed. Then we get to type 3. So now you have both your AC and CC ligaments are torn. So you're going to have both instability in the horizontal section and in the vertical section. So the x-ray, you're going to see that AC joint disruption, and you're going to see that increase in the CC distance. And the distance is going to be 25 to 100% of the contralateral side. Now, this is still reducible. And so the treatment can be controversial a little bit, and I'll talk a little bit more about that. But most regular people are going to be treated conservatively because it is reducible. Then we move into type 4. So again, AC torn, CC torn, and here you might see some skin tenting here, and you might see some posterior fullness. So this is when I mentioned before that axillary view. This is where it comes in handy, because here's your axillary view here. And you could see posterior displacement of that lateral clavicle. So you would expect, here is your acromion here, so you would expect your distal portion of your clavicle to be right here, but it's actually posteriorly displaced. And this is not reducible. There's actually displacement through the trapezius muscle. So this is actually going to be surgical management. And then we go to type 5. So type 5, again, AC torn, CC torn. And in this one, you're going to see some severe shoulder droop. It doesn't get better with a trap raise. In this one, you're going to see an increased CC distance of more than 100% of the contralateral side, even up to 300%. And this one is not reducible either. and this is surgical. So greater than 100% difference in the CC distance on the contralateral side, it is going to be surgical management. And then type 6, this one's pretty rare. It does have some association with other injuries because you're talking about an inferior dislocation now of that lateral clavicle. And it's either going to be pushed into the subacromial or the subcoracoid space. And so you can imagine with all of the structures that lie in here that you may potentially have some other injuries, neurovascular injuries. This is also not reducible and will be surgical. So non-operative treatment, like I said, the majority of these are probably going to be treated non-operatively. You're going to have your type 1, type 2, and most times, most individuals, type 3. So you're going to do brief sling immobilization just so that you can get that pain under control. And as soon as that is kind of under control, we want to get that early range of motion. We want to regain functional motion by 6 weeks, return to normal activity by 12 weeks. And then complications, you can definitely see some AC joint osteoarthritis. And then depending on how severe the tears were, you can definitely get some chronic subluxation and instability with these, more so in maybe the type 3s. So then we talk about the operative management. So really what we're trying to do, so you can have an ORAF versus a ligament reconstruction, but really what we're trying to do is restore that CC interval and improve stability. So for these, the acute type 4, 5, and 6. But then we also want to consider type 3 in people who are very active and very use their arm pretty heavily. So our elite athletes, our laborers, and then obviously people who don't like the giant bump on their shoulder. And then you can also do, if those type 3s who you tried conservatively failed, you could go back to operative afterwards. If these are the types of people, so even somebody who has a type 4, 5, or 6, kind of depending on the severity and other associated injuries, if they're unlikely to comply with the post-op rehab, really just like any other surgery, maybe you wouldn't do that surgery. Or if they had a skin problem overlying where they were going to fix the site, obviously you would want to reconsider that. But ultimately, the rehab is decent. It's definitely worse than non-surgical. So you're going to be in a sling for 4 to 6 weeks because you need to allow that deltoid to heal, and you're not really going to do much range of motion during that time. But ultimately, you'll be able to return to full activity like 4 to 6 months, and you'll actually have some stability afterwards. So summary of AC separation: traumatic injury to the AC joint, disruption of AC and potentially CC ligaments. Your diagnosis is going to be based on x-rays, looking at the AC and CC interval widening, and your treatment is going to be immobilization with early range of motion and then potential surgical reconstruction. So a little bit on distal clavicle osteolysis. Typically 20s, males. The common one we'll see is weightlifters. Risk factors otherwise are going to be traumatic injuries, history of traumatic injuries. But really, the reason, especially why in weightlifters we see this, is this repetitive stress and microfractures to the distal clavicle. And ultimately, that leads to a little bit of osteopenia. So it's going to be similar. It's going to present pretty similarly to AC joint osteoarthritis. They'll have pain at that anterior superior shoulder, but this one will be a little bit more insidious onset. And they'll notice it quite a bit, especially in lifters with bench press and push-ups, but also exacerbated with just in general repetitive loading. So they'll have that tenderness to that area and then crossbody as it would with AC joint osteoarthritis or injury. Imaging, you're going to do that same series. You're going to do your AP clavicle and your Zenka. So things that you might see, normally we're looking at this AC joint. You're going to have sparing of that acromion. But then on that distal clavicle portion, you might see some cysts, like right here, some evidence of maybe some osteopenia, some resorption and erosion. And then you could even have some tapering of the distal clavicle, or even see some widening of that AC joint because you don't really have much bone formation in there any longer. Yes, you can get an MRI. You would see like an increased signal of the T2 sequences and bone marrow edema, or a bone scan even, which you would see earlier than X-ray. But ultimately, radiographs are really what's needed. And then treatment, for the most part, is going to be non-operative. You're going to be avoid those activities that really make it worse. You can modify the technique. So for bench, you can have a closer hand grip, and then you're going to end your weight descent like 4 to 6 centimeters above the chest, and hopefully avoid stressing that joint more so. And then NSAIDs, or you can consider steroid injections. Operative would be open or arthroscopic distal clavicle incision. And these are going to be more for the persistent symptoms, even though they've tried all of the conservative things. But the issue is you potentially can have AC joint instability. If you're thinking about you're taking out a piece of that clavicle, you're now kind of disrupting that AC joint. So you could have instability now. It's definitely not a first line. So summary, painful development of bony erosions and resorption of distal clavicle, repetitive trauma to the AC joint. You're going to diagnose this usually on X-ray. And then treatment's going to be mostly conservative. Now we'll talk a little bit about SC dislocations. And this here is Texas quarterback Quinn Ewers in 2022. And he gets driven down and sprains his SC joint right there. You'll see another view. So common theme here, fall onto shoulder, seems to be most of these injuries. So I'm going to talk a little bit specifically about SC dislocations in sport. It's less than 1% of shoulder or upper trunk dislocation, so pretty uncommon. And as most of the other ones, it's also mostly young males. Shocking. And then the most common sports we're going to see it are in some contact sports, and then football, wrestling, and biking. So you can have the traumatic dislocations. And then we want to know the direction of the dislocation. So the anterior is going to be most common, which is good, because the posterior dislocations, you have to worry about all those mediastinal structures that are going to be at risk. There's also a chance that you have a clavicle physial fracture rather than just an SC joint dislocation. So it's important to just note that that's a potential and make sure that that's not the case. That area actually fuses at age 20 to 25, so it's pretty late. But this mechanism is usually going to be that high energy. The majority are MVCs and then otherwise contact sports. There are atraumatic subluxations. So this can occur with overhead elevation of the arm, and it's usually going to be those younger patients and the ones that have the generalized ligamentous laxity. So you definitely need to consider Ehlers-Danlos and Marfan's in atraumatic subluxations. And then generally those subluxations are going to reduce when they're lowering the arm. So essentially just reassurance and local symptomatic treatment for these. They don't really need a further workup or any other treatment for these. So a little bit of anatomy on this. You have that medial clavicle, and as I mentioned, it is prone to have a physis injury. So it's the first bone to ossify, but it's the last physis to close at age 20 to 25. So that's why we need to just keep an eye out for that. And then you have your SC joint in general. So it is also a diarthrodial saddle joint. It doesn't have complete bony congruence and only about 50% contact. And then there's a fibrocartilage in between it. But you can notice all of the surrounding mediastinal structures that are in that area. So you can imagine if you have that posterior dislocation, it potentially can cause some pretty bad injuries. So in regards to SC joint stability, because of that lack of bony congruence, the joint stability is really provided by these two sets of ligaments, the intrinsic and the extrinsic ligaments, as well as this intra-articular disc. So intrinsic ligaments, you have the anterior sternoclavicular ligament here, and then the posterior is on the posterior side. And then you have those extrinsic ligaments. So you have this interclavicular ligament here, and then you have the costoclavicular ligament here. And then you have an intra-articular disc as well. So that provides the majority of the stability since those bones aren't so congruent. So presentation of this anterior, as you may expect, will kind of look like this. You'll see a little bit of a deformity, a palpable bump. Posterior, you may not necessarily notice anything obvious. they may actually present with like dyspnea, dysphagia, tachypnea, stridor, and these things oftentimes are worse supine because gravity is pushing that even further posterior. On physical, the prominence that you see may worsen with arm abduction. Obviously, you may see some decreased arm range of motion and some sensory changes potentially in the upper extremity because of the structures surrounded, as well as some venous congestion or pulses that are abnormal. So you need to evaluate for that. And you do need to consider associated injuries. So even with those anterior dislocations, you can get a hemothorax, pneumothorax, rib fractures, pulmonary contusions associated with them, because this is the chest wall now we're talking about. But with that posterior dislocation, we even more so need to be concerned about other injuries, including those, but subclavian vascular injury, esophageal, tracheal injury, brachial plexus injury, and then even cardiac dysrhythmias. If you think about all of those things that are located in the central chest, there is the potential for injury. So diagnosis, at the minimum, x-rays, and these will include AP and serendipity views. So here we have an AP view here. It's not always easy to visualize the SC widening. You can see it in this one. You can see a little bit of widening here, but it's not always easy to visualize it. And you also can't tell if it's anterior or posterior based on this. So instead, we can do a serendipity, or in addition to, we can do a serendipity view. So we have a beam at 40-degree cephalic tilt. And so this would be a normal joint here and here. And then in this one, so for an anterior dislocation, the affected clavicle here on that right side is above the other side. So anterior is going to be above it, and then posterior is going to be below it. So over here, this is a serendipity view, and you could see that left SC joint, that clavicle is above. So we're going to think this is an anterior dislocation. CT is really going to be your gold standard. You're going to look for comminution, you're going to look for bone fragments, you're going to look for physes, you're going to look for vascular injuries, other thoracic injuries. And so CT is actually pretty important in these, especially with posterior dislocations. You can also, I think I mentioned this already, you can differentiate from the physial fractures here as well. So non-operative treatment, those atraumatic subluxations, non-operative. And then also chronic anterior dislocations with not really much symptoms, those are also going to be non-operative. And generally, this is just going to be a sling for comfort. And by 3 months, they should probably be able to return. Operative, you have a couple different choices. The first is closed reduction under general anesthesia. And these are going to be those acute dislocations, whether anterior or posterior. And if that closed reduction is stable, they can be put in this Velpo bandage for 6 weeks. They could start doing elbow exercises at 3 weeks and hopefully return to sport at 3 months. If that reduction's unstable, either the person's going to be like, all right, well, I'm going to have this weird deformity, or they can go in and do an open reduction and soft tissue reconstruction. So that's the next method. In addition, this can also be an acute posterior dislocation, or that this can be with failed reduction or anterior that remains symptomatic. And especially people that have that persistent like dysphagia, shortness of breath, or obviously decreased peripheral pulses because it's putting some pressure on the vasculature. So summary of SC dislocations, they're pretty uncommon. They can be traumatic or atraumatic. Your diagnosis, you have that AP X-ray view, but more so that serendipity view, but ultimately CT to assess other injuries and displacement. Your treatment's going to be either observation, especially with those atraumatic ones, or with chronic anterior dislocations, and then surgical for the acute injuries. Now moving on to clavicle fractures. So here we have in 2019, Washington Capitals winger TJ Oshie, and he had a right clavicle fracture from smashing into that board there and had some surgery to repair that. And 2013, Aaron Rodgers from the Packers decided to break his left clavicle. And then again in 2017, he decided to break the right clavicle. So you could see these mechanisms are very, very, very similar. And he did undergo surgery for these. Um, 5 to 15% of all fractures and up to 50% of all shoulder fractures are clavicle fractures. We separate these into thirds. So 80%, the majority, are going to be the mid shaft, middle third. The next most common, 15%, are going to be distal, and 5% are going to be medial. Midshaft is the most common by far. It's the thinnest part of the bone. It's the only part of the bone not reinforced by attached musculature and ligaments. So this is why this is most common. And surprisingly, again, we see these in young adults, especially males, though also older females. And it is the most common, commonly associated fracture with birth. As usual, presents with anterior shoulder pain, maybe some swelling, ecchymosis, tenderness. People will often come in holding their elbow with their unaffected arm for support. Sometimes you'll see a deformity. Sometimes you'll see skin tenting. With the skin tenting, we'll generally see that with the middle or medial third fractures, just because those are more likely to displace like that. And then you do need to consider neurovascular injuries, especially with middle third fractures, because as you can see here in this medial portion, you have that suprascapular nerve literally right there. This is that posterior view, obviously. And then you have the suprascapular nerve coming through as it passes posteriorly. So it's definitely in the way of the medial aspect of that clavicle. And then distal third fractures oftentimes can be missed and just confused with AC sprains because of how close they are to that AC joint. So imaging, again, AP Zenka views, you absolutely can consider getting that axillary view so you can get that triplanar orientation again. But if you need better detail, obviously CT is available for that. There are so many different classification systems. Most of them are going to be describing the thirds again, but location along the shaft, whether it's angulated or not, comminuted, degree of overlap, which measurement is important for, and then involvement of those corticoclavicular ligaments. In addition, you also want to know if there's any other things. So if you have associated AC or SC abnormalities, glenohumeral joint abnormalities, scapular fracture abnormalities, because what ends up happening, and I'll talk a little bit more about this later, but you can get what's called a floating shoulder. So this is the superior shoulder suspensory complex. It's a bone and soft tissue ring. And ultimately, if you have two disruptions within this ring, it's considered a floating shoulder and you're not stable. So it includes here the glenoid fossa, the coracoid process, the corticoclavicular ligament, the clavicle, the AC ligament, and the acromion. And so any two of those together can be considered a floating shoulder. And then obviously, again, clavicle lies up on the chest wall, so you have to consider other traumatic injuries, rib fractures, pneumothorax, neurovascular injuries, those things. So in talking about the distal or lateral clavicles, we have the AO classification system here. There's just a bunch. So ultimately, you want to know whether it's extra-articular or intra-articular, whether there is involvement of ligaments, and whether there's displacement, because all of that will play into whether this is operative or non-operative. And so depending on what you're using here, and obviously you don't need to memorize these classifications because there's 9 million of them, so you always want to look them up. But here, these are stable, and so those are all going to be non-operative. Midshaft. This is much easier. If you're non-displaced, less than 100% displacement, non-operative. If it's displaced, more than 100% displacement, operative. Much better. And then you have your medial or proximal fractures. So The true rate of non-union and outcomes with this isn't as defined because these are much more rare. The proximal clavicle actually, like the proximal clavicle and SC joint actually have pretty good ligamentous support, so that when fractures happen, they usually don't displace much. And so these tend to not happen very often or very minimally displaced. But otherwise, again, you're looking for displacement, whether there's involvement of the articular surface, you have that epiphyseal separation I was kind of talking about with the SC joint dislocation, or whether it's comminuted. So for non-operative treatment, generally the non-displaced, minimally displaced, that less than 100% displacement, less than 2 centimeters shortening, it's going to be non-op. We talk about closed reduction. People used to always do these figure-of-8 braces. They don't stay. So then we talk about sling versus figure-of-8, and they actually both have very similar outcomes, but slings are much, much, much more tolerated than figure-of-8. People have a lot of discomfort with the figure-of-8 bracing. So we now go with the sling. You want to go with limited elevation of that shoulder until really they're starting to clinically heal. You can repeat some imaging just to make sure there's no increased displacement. But really, these are also over the first couple of weeks. Yeah, maybe they're wearing a sling as needed, but gentle range of motion at 2 to 4 weeks, start strengthening at 6 to 10. And then as soon as they're non-tender, they have full range of motion, they can start returning to play. Usually it's about 4 to 6 months. There's still a non-union rate of about 15%, with risk factors being like female, older, smoking especially. But even so, up to 50% of people with radiographic healing still may have some long-term symptoms or some limitations in their activity. So it's just something they may end up having to deal with or consider surgical management. So absolute indications for operative management, we're going to consider obviously open fractures or impending open, so that's skin tenting. If they have vascular injury, that floating shoulder we were talking about, or symptomatic non-union, as I had just mentioned. And then otherwise, the more relative ones are those injury patterns we talked about earlier. And then brachial plexus injury is one of those. That one's actually relative rather than you would think, oh, that's going to be an absolute. But it's like 60, so it's like 2/3 end up having spontaneous return of normal function. And so it's like, well, do we really need to do that then if the majority end up getting all of their function back regardless? And then you need to consider other things like a seizure disorder. So if they're at risk for future displacement because of subsequent seizures, you may need to consider fixing something. Or if they had polytrauma and say they have lower extremity injuries and they need help like with walking devices, you may want to do surgery so they can actually use that arm to help them. And then the surgery is generally going to be either plate or fixation with the nail. And then they're going to be in a sling for, a week or so and then start range of motion. They're going to avoid like full range of motion for like a month or so and then start their strengthening. And usually full activity at about 3 months. The advantages of this, you obviously get are higher union rates. It's going to be faster. They're going to have a good outcome for the most part, but then you also get symptomatic hardware, likely going to need a removal, potential infection, but so, need to weigh risk and benefit, obviously. So summary for clavicle fractures: direct blow, fall into shoulder, outstretched arm, 5 to 15% of all fractures, up to 50% of all shoulder fractures, with the middle third being the most common. Imaging diagnosis can be X-ray, and treatment is mostly going to be non-op with a sling. All right, last section, scapula fracture. Okay, so this is the 2017 Tour de France. Mark Cavendish is trying to pass Peter, I don't know how to say his name, Sagan, in the sprint, and he's coming up on the right. And you'll see he gets elbowed right there and smashes that posterior shoulder into the divider. And then he gets run over and his legs in his helmet. That part has nothing to do with this lecture, but I obviously, as an emergency physician, I find this interesting. Poor Mark, he's okay now. And he was actually treated non-operatively. So the incidence of scapular fractures is decently rare. It's less than 1% of all fractures, so 3 to 5% of shoulder girdle fractures. And these are going to be seen more commonly in males than females again, and in that middle 25 to 50-year range. Location, majority are going to be the scapular body and spine, which is good. And then we come down to the glenoid. After that, then acromion, then coracoid. So in general, high injury trauma or energy trauma, mostly are going to be MVCs, more than 70%. You can have that indirect trauma through that fall on the outstretched hand as well. And then you need to consider glenohumeral dislocations, like general, as we talk about, shoulder dislocations. But with an anterior dislocation, you can actually get an anterior rim fracture. That's a scapular fracture. With posterior dislocations, you think about posterior rim fractures. That's also a scapular fracture. So other associated injuries you also need to consider. Rib fractures, actually decently high percentage associated, 53%. Association with rib fractures and with scapula injuries. And then ipsilateral extremity injury like clavicle, spine fracture, pelvis fracture, vascular injury, brachial plexus injury. This is definitely something that needs to be worked up for sure. And then medically, thoracic injury like a hemopneumo, pulmonary contusion, and head injury as well. So this is it's like a huge part of your body, the scapula. Origin or insertion of 18 different muscles. And essentially it's connecting your spine, upper extremity to your thorax. So you have 4 major processes. You have your scapular spine here, you have your glenoid, you have your acromion, and then you have your coracoid process. And all of these are considered scapular. When you have injuries to any of these, it's considered scapular fracture. So you have your glenohumeral joint, which provides a lot of the motion of the shoulder, obviously. You also have a scapulothoracic joint. It's not a true joint per se, but it does articulate with the thorax and the scapula. And it does have absolutely some motion. Then you have your AC joint, and then that superior shoulder suspensory complex I mentioned earlier. So bone and soft tissue ring, it connects the glenoid scapula to the axial skeleton. So it has those 4 bony landmarks and those 2 ligamentous complexes. And the 2 different pieces are disrupted, floating shoulder. So that biomechanics, I mentioned the glenohumeral joint. So 2/3 of the shoulder motion is the glenohumeral joint, but 1/3 is actually the scapulothoracic area. So this is actually a big portion of our motion. Obviously consider the blood supply that can be involved with fractures, and then definitely consider nerve injuries. So brachial plexus, right around that area. You also, that axillary nerve is at that inferior glenoid as it comes around to that posterior aspect. So you have to consider that in injury. And then also that suprascapular nerve. So it comes right in here at the suprascapular notch. And then if you have compression there, you have to worry about supraspinatus, infraspinatus weakness. If you have injury or disruption as it comes out from the sphenoglenoid notch, then you consider just the infraspinatus weakness. So definitely those things need to be evaluated as well. Oh boy, so many classification systems because there's so many parts to the scapula. So general scapula body fracture, great. We're like, oh, look, it's the body. It's comminuted, non-comminuted. Essentially, that's pretty much it. Not really, but close to it. Then you have your scapular neck, and you need to consider whether there's ligament disruption, whether there's clavicle fracture association, because now you're talking about that, that suspensory complex. And then you also need to consider, because it's in that scapular neck, you need to worry about those, the axillary vessel and brachial plexus injuries. And then you're talking about glenoid fractures, and you have all of these types of glenoid fractures, and they could be intra-articular or extra-articular. So then when you talk about the acromion fractures, you have the Kuhn classification. So you go from minimally displaced here, or the avulsion here, which are pretty minimal, to you have some displacement, but the subacromial space is fine, to you have some impingement of the subacromial space, and that's obviously a little bit more of a concern. And then with coracoid fractures, you have the Ogawa classification. And this one's great. This one's super easy. Essentially, you're just relating it to proximity to the coracoclavicular ligaments. If it's distal, it's a type 2. If it's proximal, it's a type 1. I love that one. It's the best. So you're going to think about a direct blow to the shoulder or the fall on the arm. And then there can be so many other distracting traumatic injuries that sometimes it's missed or it presents later. And this, they're going to have severe diffuse shoulder pain. They may have some shortness of breath or chest wall pain, not even just because there's like another injury, like a rib fracture or something associated. But if you think about how your scapula sits on your thorax, anytime you move your arm, anytime you breathe, your chest wall is going to hurt. And then the physical, you may just get some diffuse tenderness to the scapula. It's not very accurate to try to pinpoint an area by, with an area of tenderness. It's not very specific. It's pretty inaccurate. So then obviously the normal things, look for contour abnormality, open wounds, like an open fracture, swelling. Hopefully try to avoid some active range of motion just because this can be very painful, but you can try some passive range of motion to see if there's a mechanical block. And then obviously checking that neurovascular status. So imaging, you have the AP of the scapula. So in this area, you can look for medialization of the scapula, the lateral border. You also have the lateral Y view here. And then this one's really good to measure angulation. You have your Gracie. Your Gracie is the true glenohumeral view where you can actually see the glenoid pretty well. But this one is good for the glenopolar angle measurement. So connecting the superior inferior scapula to the lateral border of the scapula. And then also consider doing an AP chest just because you're looking for other injuries as well, pneumothorax, but you can also look for widening of the medial scapular border and spine. So like if you look, here's a normal scapula here in the back and look at where this one is. It's crazy. So here you can see there. So this is actually scapulothoracic dissociation. Also not very common, but interesting. Imaging, CT, intra-articular fractures, displacement, concern for other injuries. That's going to be the majority of it. MRI, sure, maybe if you're looking for that superior shoulder suspensory complex, like looking for that ligamentous injury, you may consider it, but that's not going to be the majority of what you're going to use. So non-operative treatment is going to be for scapular body is going to be the majority non-operative. 90% are going to be minimally displaced and acceptably aligned well. So you're going to do a sling for a couple of weeks, early range of motion, just like as you would with many other things. However, if you have especially underlying rib fractures or that suspensory complex concern for a disruption, there is a very good chance that it might displace. So with these, we want to do serial x-rays every week for 3 weeks just to make sure that it doesn't displace any further. And then if it doesn't, you're generally going to say, yep, just like anything else, union in about 6 to 8 weeks, and most do fine. But if you have, and I'm not going to go over the specifics of it, but there are specifics if you have angles and displacement, medialization of certain measurements or angles, then those would be surgical considerations. For the scapular neck and glenoid, it's going to be the same. You're going to look up, what do we need to worry about? Truly, it's going to be those numbers again, the measurements and the angles. Or if there's injury to that suspensory complex, that's generally going to be operative. And acromion and coracoid, also any injury to that suspensory complex, I'm going to consider operative repair. Otherwise, these are 1 and 2 of the acromion fractures. These ones are going to be non-operative, especially if displaced less than 10 centimeters or 10 millimeters, sorry. And then with coracoid, really any Ogawa 1, this one down here, with a displacement of less than 10, or any at all Ogawa 2, because it's distal to that CC ligament, you really don't need to do anything with that one at all. Okay, so summary of scapular fracture, uncommon, high energy trauma, associated with many other injuries potentially, radiographs and CT for diagnosis. Treatment's usually going to be non-operative with a sling in the vast majority of them, but you do need to know about those other ones that potentially could need some assistance with surgery. Some tiny little references that you probably can't see. And now I'm going to go on to some, actually, I'm going to stop share and I'm going to reshare so that I can move this. What I want you to do is get your phones out if you don't have it already, so that you can take this poll and answer the questions for me. Okay. So you'll just use your phone to scan that QR code up there. So you have a 25-year-old competitive mountain biker who comes to the office with a left shoulder injury sustained when he crashed during a race 3 days ago. So evaluation confirms an AC joint injury. You have comparison radiographs of the injured and uninjured AC joints, and you see elevation of the left clavicle greater than 100% difference in the CC distance. So which of the following best describes this injury and recommendation? Greater than 100% distance. So far, we have a tie for, oh, not anymore. Right, you get 30 more seconds. All right, we have a tie for B and D. The answer is D. So rockwood is what we use for classification mostly. And when we talk about greater than 100% increase in the CC distance, this is a type 5 separation, which is surgical. Non-operative is generally not recommended for this high of an injury, so that is why C is wrong. And then type 3 separation only has that 25 to 100, so it's capped at 100. That's the type 3. That's why B is wrong. And then A is wrong because, oh boy, I messed up. A is wrong just because it's not non-operative necessarily. Okay, now you have a 17-year-old. Sorry, guys, I'll get there. Okay, 17-year-old female with a popping sensation in her chest that she's had actually for a long time. She just noticed it got worse after a slide tackle in soccer yesterday. States it doesn't really hurt. On exam, she could reproduce it by abducting her arm over 90 degrees. You appreciate a clicking sensation with palpation of the SC joint, but no deformity. So what management is indicated? Good. I feel like we just keep adding on to the correct answer. Obtain x-rays if normal and discharge to outpatient follow-up. So this patient's essentially describing a history of sternoclavicular laxity. And so it can be associated with overuse, but can be also genetic. So like Ehlers-Danlos, as I had mentioned, or Marfan's. And so they can have like ligamentous laxity at any joint, so including the SC joint. She probably sprained it in addition in the slide tackle. And so because it's sports related, we generally get x-rays just to make sure there's not something else going on. But ultimately, as long as She does okay. She doesn't really need to do anything else. She doesn't need to see anyone else. Generally, the treatment's going to be physical therapy, maybe a sling for comfort if needed, maybe some NSAIDs, and then just graded return to play. Really, what you want to consider with SC joint is stabilizing the anterior chest and neck muscles. Okay, which of the following statements is true concerning clavicle fractures in athletes? And this is the last one. Okay. Most of you got this right. My dogs agree. Non-operative treatment of acute midshaft clavicle fractures with either sling or figure of 8 have similar outcomes. So they do have similar outcomes, but the sling is preferred because it is much, much, much easier to tolerate. So immobilization for A is incorrect. Immobilization is essentially just for comfort and really only needs to be in place for a couple of weeks, just as most of the pain subsides. And then you really want to start doing some early range of motion. We don't want that stiffness. We want to progress them as able. And then B is incorrect because the CC ligaments are the primary restraints preventing vertical displacement. And then D is incorrect because fractures of the proximal third of the clavicle are pretty uncommon and really have good ligamentous support. So when they do occur, they tend to not displace. Okay, I think that's all I got.
All right, thanks, Dr. Lane. We do have one question in the chat, and it talked about more, if you can give any more details on how you would reduce like a type 3 AC joint separation. They also asked for type 1 and 2, but my assumption is that you're not reducing those, but the type 3, is there anything you can do for those?
You're truly not trying to reduce it non-surgically. That was like the figure of 8 would be the attempt to like reduce it in that sense, a figure of 8 bandage, but we're not really trying to reduce it. You're testing it to see if you have stability, but you're not reducing it necessarily yourself.
Perfect. Okay, let me just share mine real quick. I'm gonna see if there's any other questions that are gonna come in here at this point in time. Do not see any right now, so let me go ahead and change this real quick here. And let me go here. And all right, so yeah, I think that's it. I'll say thank you, Dr. Lane, for
we did have one more in the chat.
Oh, we do
there,
have one
Myro.
more. Okay,
Yeah.
let me see here. And Dr. Lane, oh, would you also reduce a type 4?
Oh, I'm not trying to reduce any. You can't really keep a reduction.
Yeah.
In AC injuries, so unless it's surgical, so I'm not trying to reduce any of them. And it doesn't. You can't really reduce it.
Gotcha.
So
that's more just comfort. Get them to the surgeon then, huh?
Yep. Exactly.
Okay. Perfect. So, and let's see. Hopefully everybody can see my screen now. Yep. So thank you, Dr. Lane. I think that is the last question right there. So no, I appreciate the discussion and all the videos which showed the mechanism of injury for each topic. So that was actually really good. And I liked how you integrated the pull everywhere in there at the end. So thank you. Thank you, Andy, for your assistance with the lectures. And if you guys haven't seen, look in the chat and there is a link to the evaluation. And then please join us next week as Dr. Catherine Ackerman will be giving us a talk on transgender athletes. So thank you.
All right, thanks.